Good evening, everyone, and welcome to tonight's APSC-EECC Co-Cardiology Review Series. And I'm Dr. Zhang from Taiwan, and today we're moving forward to the episode 4. And so today we'll talk about pulmonary hypertension, adult congenital heart disease, and also a special topic about the cardio-obstetric. So today we'll about have 1 and 15 minutes. So this APSC society societies in collaboration with the European Examinations in Co-Cardiology, EECC, presents a Co-Cardiology Review, a webinar series designed to provide comprehensive updates on various co-cardiology topics. And also there's preparations for cardiologists in APSCs to take the EECC test. And here are our wonderful co-directors and also advisors. And also, I want to introduce today's chair. So I'm Dr. Zhang from Taiwan, and also we have the other 2 excellent chair. It's Dr. Leong Ming Chern, and is a consultant pediatric cardiologist in Malaysia. And also Dr. Ezman, and I think everyone is very familiar with him. And he's also a consultant cardiologist from Malaysia. And today we also have 2 wonderful speakers. And the first is Dr. Rina Ariani, and she is a consultant cardiologist from Indonesia. And the next topic will be spoken by Dr. Jia-Ling Lin, and she is also a consultant cardiologist in Taiwan. So some housekeeping things I want everybody to know that the content of this webinar is copyrighted by APSC, and also the views and opinions expressed are those of the faculty members and do not necessarily represent those of APSC. And also this webinar is live streamed by APSC Facebook and the YouTube pages. And also after this episode, you will receive your certificate of attendance upon completing a survey and also sent by email. And here we can see there's a button here, and this is a QA. So you can just type your questions, and after the lectures, and then all the chair will collect the questions, and we will have very fruitful discussion about that. Also this upcoming webinar. So the episode 5 is talk about the coronary disease, and it will be held in January 22nd next year. So let's get started. And so let me introduce the first speaker, Dr. Rina Ariani. And she is very experienced in the pulmonary hypertension, also adult congenital heart disease. And she is also a consultant cardiologist from Indonesia. So, and just give the floor to Dr. Ariani to start with the first lecture. So please.
Thank you, Dr. Wei-Ting, for the introduction. First, let me share my slide. Okay.
Good.
Okay. Is my slide present okay?
Yes, perfect.
Okay. Thank you, Dr. Wei-Ting again. Good evening, everyone. Thank you for inviting me to be part of this EECC Core Cardiology Review. The task given me is about 2 broad topics, actually, about pulmonary hypertension and adult congenital heart disease. So hopefully we can pack those 2 topics in a 20-minute presentation. This is the outline of my topics. As we know that these 2 topics is quite huge, so I think I'm going to cover only the basic and principal things of these 2, and we can read about it more detail in the guideline. So chapter 1, we're going to talk about pulmonary hypertension. Most of the topic and the recommendation come in this presentation came from 2022 ESG guideline for the diagnosis and treatment of pulmonary hypertension. So unless it's stated otherwise, so the reference will be from this guideline. So we all know in 2019, the definition of pulmonary hypertension become lower, have a lower border, lower limit. It become mean pulmonary artery pressure more than 20 millimeter mercury at rest and diagnosed with right heart catheterization. And we also noted that the cutoff point for pulmonary vascular resistance were also being decreased from 3 to 2 Wood unit. to make the diagnosis of precapillary pulmonary hypertension. Prevalence of pulmonary hypertension is not that big, actually, only 1% in global population. It affects all group and mostly increase with age. The etiology is multifactorial, and it is a progressive disease leading to right heart ventricular failure and subsequent death. So this is going to be the classification of pulmonary hypertension. This is the group 1, the one that mostly discussed in the 2022 guidelines. It consists of connective tissue disease, such as systemic sclerosis, connective tissue, SLE, Sjogren syndrome, rheumatoid arthritis, and other connective tissue disease. There are also pulmonary hypertension, congenital heart disease that is quite much in my country, due to uncorrected left duration, or cyanotic heart with unrestricted pulmonary blood flow. And the second one is probably the biggest group or the biggest component of the pulmonary hypertension. The prevalence is about, can be more than 80%. It's due to the left heart disease. It can be due to left ventricular systolic or diastolic dysfunction, valvular heart disease, or even congenital acquired in cardiomyopathy. It is the common cause of pulmonary hypertension, cardiovascular comorbidities, atrial fibrillation, previous vascular intervention, and structural left heart disease become the risk factor for this group. The third group is the pulmonary hypertension due to lung disease. It consists about 15 to 40% of the population of the pulmonary hypertension. It can be caused by many wide range etiology of pulmonary disease, from chronic obstructive pulmonary disease to interstitial lung disease and alveolar hypoventilation disorders. There are also chronic thromboembolic pulmonary hypertension and other pulmonary hypertension that cannot be packed into other groups, so it put in the group 5 category. So this is the pathophysiology of the pulmonary hypertension. It all started in a patient with risk factor or a patient with associated conditions such as collagen vascular disease, congenital heart disease, drug, toxin, or even pregnancy. And there's also some patient who have abnormal gene or susceptible genes. These things will will have endothelial injury due to decreased nitric oxide synthesis, prostacyclin, thromboxane, and endothelin. And all these things that will be the target of medication later on. And all these things will make the pulmonary artery become hypertrophy. There will going to be early intimal proliferation, and at the later stage, there will also thrombosis and more advanced vascular lesion that become irreversible. And when these things happen, there will be right ventricular pressure overload, and in the end, there will be right ventricular failure. So this is the diagnostic step for pulmonary hypertension. It all started from suspicion. It can come from the medical history, physical examination, either from simple supporting exams such as ECG or biomarker. And then if there is a suspicion, we can come to the second step, which is detection. We can do this even if either with non-invasive lung test, or the more used one is the echocardiography. And then if the patient has intermediate or high probability, or even the patient have present a high risk factor for pulmonary arterial hypertension, or the patient has a history of pulmonary embolism, we can go to the confirmation stage by doing right heart catheterization or other tests to determine pulmonary hypertension classification and etiology. We should keep in mind that in patient with rapid symptom progression, patient with severely reduced exercise capacity, patient with more severe presentation, patient with compromised hemodynamic status can go directly to immediate assessment and referral to pulmonary hypertension center. I just like to emphasize the importance of echocardiography in detecting probability of pulmonary hypertension. We all, from several guidelines, it's already stated that echo is not for the diagnosis of pulmonary hypertension, only to make the probability of pulmonary hypertension by using the TR Vmax velocity. And then if we have another indirect echo sign for pulmonary hypertension, the probability can be upgraded into more one step higher. So we have to remember that to do this, we need to have a very well-defined envelope of TR-JUT. This is the summary how the echocardiography indirect sign can upgrade the probability of pulmonary hypertension. It is divided into the ventricular group, pulmonary artery group, and then right atrium and IVC group. We can see here we need at least 2 parameters from 2 different categories until we can change the probability. We can upgrade the probability of the patient with pulmonary hypertension. And after we make the diagnosis, the right heart catheterization already confirmed that the patient have pulmonary hypertension. We have to do is to do pulmonary vasoreactivity testing. We can do it by either iloprost or nitric oxide. And then if the patient is called vasoreactive, by definition, it's by increase by more than 10 millimeter mercury drop of mean pulmonary artery pressure to less than 40 millimeter mercury with increased or unchanged cardiac output. If this patient has vasoreactive, so we can give a calcium channel blocker to the patient and then reassess again after 3 to 6 months. If the patient cannot develop a good result, if the functional class is still not okay or cannot put into a low risk category, then the patient should be assessed into the next step for risk stratification. If the patient is non-vasoreactive, we have to look out whether the patient have cardiopulmonary comorbidities or not. If the patient has cardiopulmonary comorbidities, then we can start the patient with first oral monotherapy with either phosphodiesterase 5 inhibitor or endothelin receptor antagonist. And if the patient has no cardiopulmonary comorbidities, and then we can go to make risk stratification. So this is the risk stratification for the first step before we make the we decide what to do to the patient. There are two widely known risk stratification score, either by ESG-ARS classification or by this refill 2.0. And then by these two parameters, we can decide whether the patient falls into a low intermediate risk or into a high risk criteria. And then after we decide if the patient was in low or intermediate risk, we can start with a combination of 2 drugs. But if the patient falls into high category, the patient can start with a triple combination of pulmonary hypertension drug. And then after we give the first initial treatment, we can have a regular follow-up assessment. And at this stage, we can re-stratify the patient by using this four strata calcification by using more simple parameter, but we must use all these parameters to decide on which group this patient fall into, and the patient, and that we can classify it into low, intermediate, high, and a high risk patient. By evaluating either functional class, 6-minute walk test, biomarker, either natriuretic peptide or NT-proBNP. And then after that, we can add or we can continue the treatment according to the classification. So this is just a slight review or a slight review about what drug we use for the pulmonary hypertension, pulmonary arterial hypertension. Basically, right now the approved one is only for these 4 category. If we include calcium channel blocker signaling pathway in this, which is only can be given to the patient if the patient is have a positive vasoreactivities testing, or if not, we can go with between this endothelin 1 pathway such as ambisentan, bosentan, and macitentan, the prostacyclin pathway either by epoprosterenol, berapros, Alexipax, and ilopros. We should keep in mind that this berapros in European is not approved. And then by nitric oxide pathway, by either the PDE5 inhibitor or using guanylate cyclase inhibitor, by sildenafil, tadalafil, and risosiguat. And then next chapter would be about adult congenital heart disease. Again, this second chapter, we are going to refer the reference into the 2020 guideline for adult congenital heart disease. And I'm only going to cover the most basic adult congenital heart disease and the clues involved in this patient. The first one is the atrial septal defect. This is frequently in adult, usually asymptomatic until well into adulthood. And usually the symptom is not quite pathognomonic also. The symptom varies from reduced functional capacity, shortness of breath, palpitation, and less frequently pulmonary infection and right heart failure. We can find a fixed splitting of the second heart sound and a systolic pulmonary flow murmur. On chest X-ray, we can see an increased pulmonary vascularity on checks on and dilated right ventricle. There are 4 types of atrial septal defect. 2 types actually, there is actual defect of the interatrial septum. We can categorize into a secundum ISD or primum ISD. And the other 2 is not that physiologically behave like interatrial septal defect, but actually not. It is a sinus venosus ASD defect and unroofed coronary sinus. This is the clue for primum ISD. Usually on ECG, we can find a left axis deviation and first degree AV block. On echo, we can see that tricuspid valve and mitral valve usually stand in one level. So it looks like a T-wave appearance. And we can see the defect is seen directly below the atrioventricular valve. And ISD, primum ISD usually associated with mitral cleft and also inlet VSD to make atrioventricular septal defect. For secundum ISD, this is the most commonly seen. The ECG finding usually right axis deviation and incomplete or complete right bundle branch block. In echo, we can see more centrally located gap, and so we usually can see rims in between the gap. And usually, if there is a mitral regurgitation, we must note whether the mitral regurgitation due to the mitral valve flare-up that usually associated with secundum ISD. For sinus venosus defect, it's sometimes challenging for diagnosis. The ECG is quite the same with secundum ISD. The echo usually we find it in the most posterior superior part of the septum, so it's usually directly seen gap from the roof of the atrium, and usually the TEE will be more superior to diagnose this as sinus venosus defect type. We can see whether it is an SVC or IVC type of gap, and usually it is associated with anomalous pulmonary veins drainage. And for unroofed coronary sinus, it usually seen associated with persistent left superior vena cava syndrome. And usually in adult, we can diagnose with agitated saline contrast from left brachial vein injection. And from echo, we see a dilated coronary sinus and a sign of right heart overload. And sometimes we can see a total anomalous pulmonary vein drainage to a coronary sinus. In this TEE, we can see that there is a connection between the sinus coronarius and the left atrium clearly. The second anomaly is ventricular septal defect. It is actually the most common congenital abnormality, maybe because often it's can occur as an isolated defect or part of more complex anomaly. In adult, it is said that mostly have been diagnosed and treated before adulthood. So usually in adult, it's either very asymptomatic or patient present with a heart failure condition. So whether the patient is asymptomatic or in stage of heart failure usually depend on size of the defect, whether the pulmonary artery pressure and the age of the diagnosis. We can hear the pansystolic murmur at left sternal border, and usually the intensity will decrease along with the increase of pulmonary artery pressure. And in significant VSD, we can see the sign of LV volume overload. This is the type and location of VSD. The first one, there are many names of it. It usually can be as outlet, supracrystal, subarterial, subpulmonary. It is sometimes said doubly committed VSD. This is most common except for the Asian population. And this type of VSD, we must remember that this type of VSD cannot close spontaneously. And because it is subaortic, it is usually related with prolapse of right coronary cups and sometimes aneurysm of sinus valsava. In echo, we can see the defect usually seen from parasternal short axis at 1 o'clock area. And in large VSD, we can see malalignment of the outlet septum. And the second one is the membranous VSD, probably the most common type, approximately 80% of all defects. It can, because it's a membranous, it can develop into an aneurysm, and this aneurysm can make the defect smaller or even closed. And this membranous type can extend to inlet or even outlet. And by echo, we can see that the gap at the parasternal short axis view will come from the 10 to 11 o'clock area. And the third type is the inlet or the atrioventricular canal or the FVSD type. It's usually combined with the primum ISD. It's only 8% of all defect, frequently associated with Down syndrome, especially in patients with common AF usually we see it directly below the mitral and tricuspid valve. The mitral valve and the tricuspid valve, same as ISD primum, we see it at one level. And then, so we usually see it more clearly at the 4-chamber view from echo. The next one is the muscular type. It's up to 20% of VSD. Usually it's come in multiple VSD. Sometimes it has a switches holes like appearance, and if small, it might close spontaneously. So it can be seen in any muscular part of the ventricle. Usually we can see it clearly in the short axis or 4-chamber view. So the natural history of ventricular cephal defect, if uncorrected, it can go to spontaneous closure. In hemodynamically non-significant or restrictive VSD, usually asymptomatic. It can it can have a sign of LV volume overload in hemodynamically significant VSD. It can go to pulmonary hypertension, even to Eisenmenger syndrome. Patient with VSD can develop double chamber right ventricle also due to Venturi effect. There can also be a prolapse of right coronary cups in patient with subaortic type, and there is also a risk for endocarditis and arrhythmia. The next one is patent ductus arteriosus. We know it's a communication between the proximal left pulmonary artery and descending aorta distal to the left subclavian artery. In children, it's related with prematurity, birth at high altitudes, and certain infections during pregnancy. Manifestation in adult usually depends on the size of the PDA and the age of presentation. It can go asymptomatic, heart failure, in pulmonary hypertension, even in Eisenmenger syndrome. From the classic finding, we can hear machinery murmur, and as the pulmonary artery pressure increase, the intensity will lessen, and the diastolic phase murmur will become shorter and cannot be here even. And in the later stage, we can have Eisenmenger syndrome. And in this kind of patient, we will have a differential diagnosis between the upper extremity and the lower extremity. For what to evaluate in adults, sometimes it is quite difficult to see it, and sometimes if especially in patient with pulmonary hypertension, when the flow and the turbulence is not prominent anymore. But if we can see the PDA, we have to evaluate the size, the shape, the sun direction, and the gradient between aorta and the pulmonary. So in this left to right shunt, usually the first examination will be transthoracic, and the visualization definitely going to be better in small children and become more challenging in adult. We need TAA for more close examination, especially if for the atrial and septal abnormalities, and also to evaluate any other associated lesions such as mitral regurgitation or tricuspid regurgitation. MRI usually done to assess volume overload, QPKS flow calculation, and more detailed look of ventricular function. CT usually we reserve for evaluation of anatomical abnormality if not clearly seen by echo, and right heart catheterization is indicated in patient with estimated systolic PA pressure more than 40 or has indirect sign of pulmonary hypertension. I try to summarize how to manage this left to right shunt patient. So basically, it's becoming the same if the patient have volume overload. If the lesion is above tricuspid, we will see the right ventricular volume overload. If it's a below tricuspid shunt, we will see the left ventricular overload. Principally, the class 1 indication is patient with volume overload, or if the flow ratio is above 1.5. And without pulmonary artery hypertension, it becomes the class 1 indication for closure. If the patient has no sign of volume overload or the flow ratio is less than 1.5, we only close the ASD if only a sign of paradoxical embolism, or in VSD if there is an associated prolapse of aortic valve that causing aortic regurgitation, or if there is an history of endocarditis. It becomes more challenging in patients with pulmonary hypertension. We have to evaluate the pulmonary valve resistance and the QPKS. For patients with ASD, it is not recommended to close the defect if the pulmonary valve resistance is more than 5 Wood unit. And for the patient with VSD and PDA, is still class 2B for closure only if the QPKS is still above 1.5. How about transcatheter closure in this type of lesion? In ASD, it is only indicated for secondum ASD with the diameter usually less than 38 or less if the upsize device is needed. It needs sufficient rim to hold the device, and we have to make sure there is no other associated lesion that requiring surgery. And for the VSD, the only approved indication for transcatheter closure is only for muscular and perimembranous VSD with adequate rim from the defect toward the adjacent structure, including the aortic, pulmonary, mitral, and tricuspid valve, and it is contraindicated with all other septal defect or patient with aortic valve prolapse or Martley aneurysm, septum aneurysm. PDA right now become the procedure of choice if technically possible. Probably the contraindication for closure in transcatheter closure for PDA is only if there is no size available or if the patient is too small for transcatheter closure. It is also not indicated for silent PDA, which is a very small PDA with no murmur. For patient after correction, we have to evaluate whether there is a residual shunt, the function of the ventricle and left ventricle, right ventricle and left ventricle, whether there is a residual pulmonary hypertension or associated valve lesion, arrhythmia, and double chamber right ventricle, residual double chamber right ventricle in VSD patient. For ASD, if it's repaired below 25 years old without any abnormality, no further follow-up is needed. Other group than that, or if the patient repaired above 40 years old, or if the patient had a device closure, regular follow-up is needed. For VSD, follow-up after surgical closure is needed, or if there is a residual shunt or small non-significant shunt, or in patient with post-device closure. Patient with PDA after correction, if there is no residual shunt, there is no problem with the left ventricle, no pulmonary hypertension, does not require regular follow-up after 6 months. And the next two disease will be just a slight review about tetralogy of Fallot and Epstein anomaly. Tetralogy of Fallot is the most common cyanotic heart defect. It consists of non-restrictive VSD overriding aorta, some degree from mild to severe RVOT obstruction with deviation of infundibulary septum, and also right ventricular hypertrophy. Mostly it is a non-syndromic patient, but 20% can be part of a syndromic. And the phenotype of Fallot really depend on the degree of the RVOT obstruction that lead to subsequent degree of right to left shunt, and the net flow to pulmonary artery due to additional aortic to pulmonary arteries such as PDA or MAPSHAS. And in adult, the problem occurred either in uncorrected or after correction. In uncorrected Fallot, the problem will be a lot due to the chronic hypoxia. It can lead to left and right ventricular dysfunction, polycythemia, cerebellar abscess, stroke, vascular thrombosis. There are also hemostatic problem, endocarditis, arrhythmia, and hypoxic spell. And even in corrected Fallot, there are going to be some problem we need to evaluate, such as pulmonary regurgitation, tricuspid regurgitation, arrhythmia, such as both atrial and ventricular arrhythmia. We have to evaluate whether there is a peripheral pulmonary stenosis, aortic dilatation, a residual VSD, and residual LV or RV right ventricular dysfunction. In this 2020 guideline, there is no specific discussion or specific mention about the uncorrected Fallot. Maybe in European, they have no patient like that. So we are going to only review about the management of the corrected one. We have to remember that in patient with corrected Fallot, what we have to the concern is the pulmonary regurgitation, and the pulmonary regurgitation is indicated to have a pulmonary valve replacement if the patient is symptomatic or in patient with severe pulmonary regurgitation or at least moderate RVOT obstruction. In patient with asymptomatic severe pulmonary regurgitation, it is also has a 2A class recommendation to close if there is progressive RV dilatation or progressive RV systolic dysfunction, and there is an objective evidence of reduced exercise capacity. There are also recommendations regarding the arrhythmia, and it really depends on how we find. It can go to ICD implantation or even catheter ablation. The last one is about Epstein anomaly. I think this is only just going to emphasize how to diagnose this group of patients. The prevalence is less than 1% of all congenital heart disease. By the definition, there is an abnormally formed and apically displayed of leaflet of the tricuspid valve. The cutoff point is 8 millimeter per meter square BSA, and it makes due to this abnormally displaced tricuspid valve, there are going to be some degree of arterialized non-functional right ventricle. And sometimes for the anterior leaflet, we can see an enlarged and sail-like appearance of leaflet. The lesion can be very wide. The variation of the lesion can be very wide. It depends on the degree of the arterialized right ventricle and the leftover functional right ventricle. It can also associate it with some degree of tricuspid regurgitation, intraarterial shunting, or accessory pathway. The clinical finding can be started from asymptomatic if the degree of apical displacement is low, and it can goes to low output and profound cyanosis in patient with significant right to left shunt and severe TR. And for abstain anomaly, the recommended management will be surgical repair if in patient with severe TR and symptomatic, or in patient with progressive right heart dilatation or reduction or average systolic function. We have to remember that abstain anomaly have high incidence of arrhythmia. So in patient with symptomatic arrhythmia or pre-excitation or abnormality on ECG, we should do an electrophysiologic testing followed by ablation if needed. And the idea of paradoxical embolism should bring us to think about the closure of ASD PFO, but we have to make a careful evaluation before the intervention to exclude the more progressive fall in cardiac output if we close the defect. I think that all the review for these two topics. I hope I'm not all too late.
Okay, perfect. And thank you.
Thank you.
Yeah. Yeah. Thank you so much for this wonderful lecture, especially this beautiful, echo images. Yeah, I think it's very good for education. So actually, I think we still got a few minutes for questions. We got two questions from the audience. And the first one is talk about the perimembrane type of VSD. Let's just want to know your opinions that you would propose to close this perimembrane type of VSD or not. Yeah. Yeah, please.
In regards, you cited for the perimembranous VSD, actually it's indicated for closure, but we have to remember that for transcatheter, this is for transcatheter or for.
I think it's not only
for ASD or for ASD.
Yeah. I think it's a VSD, right? So it's perimembranane type of VSD. Yeah. So
yeah. If the VSD, we have to see whether there is a sign of LV volume overload or if the flow ratio is above 1.5. It is indicated for those kind of patient. And if not, from my slide, I think the defect is quite big. So I think the left ventricular volume overload is obvious, and the flow ratio would be more than 1.5. So in those patients, it is indicated to have a closure either by transcatheter or surgical. And then
the second one is about the abstain anomalies. I think is pregnancy suitable for females patient who has abstain anomalies, and what's the criteria for likelihood of pregnancy?
Okay. I don't know whether I'm the one who should answer the question or the second presenter, but
correct. Yeah.
I think maybe the second presenter can help me after this. But I think, like I said, the presentation of abstain anomaly can be varied in presentation. If it's have a very apically displaced tricuspid is not that big, maybe the patient can be asymptomatic and the function of the right ventricle and the cardiac output is okay, so the patient can go on to their pregnancy. But if there is a more severe condition, I think we have to evaluate whether the patient is able to go on for the pregnancy. I think it really depends on the presentation of the patient and the phenotype we found.
So, Dr. Rina, just want to hold on to this topic. It's very
Yes.
interesting, if a lot of these patients with Epstein anomaly, they are born with this condition, so they don't know what's so-called normal. They consider themselves normal. So is there a way, objective measurement that you can assess whether they are suitable for pregnancy?
I think the first one is probably the functional class, and then if there is the right ventricular function, and whether there is a right to life shunt or not. Because if there is a right to life shunt, the the patient will become high risk, becoming higher risk for pregnancy. But maybe the second panelist the second presenter can help me if there is any such an objective, special
Well, perhaps we
objective.
hold on to the answer and then wait for
Huh?
Dr. Lin to finish
Yeah.
presentation before we
Okay.
discuss this further. Will it be all right?
Yes, that will be very great.
Okay, great. I think we have another question. Okay, that subsequent question asked, in assessing pulmonary hypertension, do you use PVR or PVR index to assess
Okay,
pulmonary
this is a
hypertension?
very difficult question because we are talking about ESG European guideline. The European guideline didn't use index anymore. They just use pulmonary valve resistance without indexing this type. It's quite different from previous recommendation. So in this guideline, they just use solely this pulmonary vascular resistance. That's it. In American guideline, they use a ratio between the pulmonary and systemic resistance, and not using index also anymore.
All right. So it actually boils down to which guidelines we follow. If you follow the American guidelines, you'll be using PVR index. If you follow the European guidelines, you'll be using PVR. So
because this is a European cardiology core, because this is an European core cardiology review, I think we should stick to the European guideline. Actually, even in my center, we combine all those. In my center, actually, we combine all those parameters. We use pulmonary vascular resistance. We use ratio between pulmonary vascular resistance and systemic vascular resistance, and we also still use pulmonary vascular resistance index. We combine those parameters, and then we evaluate the result. Like you said, in this European guideline, they don't use vasoreactivity testing anymore, but in my center we still use it. But again, because we are reviewing an European core cardiology exam, I think we should stick to the European guideline.
all right. I think from the same participant, she was asking whether you can recommend the best tool to calculate pulmonary vascular resistance. Is there a best way to calculate pulmonary vascular resistance?
I think it's always the recommended one is using right heart catheterization. There is an echo measurement, many echo calculator or methods to predict the pulmonary vascular resistance, but I think the gold standard will always be the right heart catheterization. So you cannot decide whether this patient can go on or not go on based on other method than right heart catheterization.
All right. So there's actually a few methods you can use in right heart catheterization. Some people use the thermodilution method. Some people use the fixed method. Some people use the MRI calculation of pulmonary vascular resistance. So what do you, Dr. Rina, what do you use in your center then?
I think we use the fixed method.
Fixed method. All right.
Yeah,
fixed principle. Right. Yeah.
We never use MRI, and we never use echo. So we always goes by right heart catheterization for evaluate the pulmonary vascular resistance.
Right. Yeah.
If I may actually ask, Dr. Leong, seeing that you sort of dabble with a lot of adult congenital heart disease, what would your recommendation be? Because I think the modified fix at least is quite simple to do, I guess, of the three, but we all know the limitations, especially when the shunt is present as well.
Right.
So in the presence of a shunt, especially for the viewers here who might be taking exams and all that, what would your recommendation be?
I would say that if the patient doesn't have a cardiac shunt, you can use a thermodilution to calculate cardiac output and as well as the pulmonary vascular resistance. Because cardiac output, in the absence of shunt, cardiac output is the same as the flow to the lungs, the pulmonary flow. So from there, you can calculate the cardiac output, the pulmonary vascular resistance, systemic vascular resistance. If the patient has a shunt, then we tend to fall back onto the fixed principle to calculate the cardiac output. But by far, the most accurate one would still be, putting in the catheter in the lungs, and then put the patient in the MRI gantry, and then you just deflate the balloon, you get the pulmonary arterial pressure, inflate the balloon, you get a wedge pressure, and from there you calculate the pulmonary lung flows. This eliminates all the calculation assumptions, and it gives us the most accurate form of PVR. But unfortunately, this is something that not every center has.
Yeah.
So it depends on which works best for you.
Fair. Okay. Do we have any more questions from the panel?
Right.
If not, Dr. Leong, would you like to introduce our second speaker for today?
Right. Thank you, Dr. Rina, for this insightful talk. I really learned a lot. You gave a really good breadth of topics on pulmonary hypertension and ACHE. Coming up next, we're going to talk about cardio-obstetrics. Cardio-obstetrics has been improving by leaps and bounds in recent years. A lot of patients with cardiac diseases are undergoing pregnancy, which in the past they would have been advised against it. And to dive in about this topic, we have Dr. Jia-Ling Lin, who's a consultant cardiologist from the National Cheng University Hospital, Tainan, Taiwan. She's going to talk to us about cardio-obstetrics. Dr. Lin.
Thanks, Dr. Yong. Let me share my slide first. I think my slide should be on screen.
Yes.
Well, good evening to everyone online. I'm Jia-Ling Lin, a general cardiologist and intensivist. For this EECC review, so the following contents would be from ESC guideline. It will be broken into two parts. The first is for basic general concept, and the second part would for some specific diseases. For the first part, I think the previous guideline covers more details. So the first part mainly from this guideline. And for the second part, for specific diseases, we will refer to the most recent guideline for some up-to-date suggestion. Let's get started. For cardiovascular disease during pregnancy, epidemiology is changing and it differs between countries. In Western countries, it's increasing, and it's now the leading cause of maternal heart disease is now the leading cause of death during pregnancy. In Western world, hypertensive disorders is the most frequent one, but in non-Western countries, rheumatic valvular disease still dominates. And you can imagine there's not much prospective or randomized trials to guide our management, but generally consulting and management before pregnancy for any woman with suspicion of cardiovascular disease, and it should be interdisciplinary team in a specialized centers, especially for those with high risks. Pregnancy causes a lot of change. It's to meet the increased metabolic demand for the mother and the fetus. The overall change is increased cardiac output. Blood volume increase from plasma volume. It could increases up to 40%. And for cardiac output in normal pregnancy, it could increase up to 50%. Initially, it's due to increased volume from the volume increase. Later, heart rate increases contribute to cardiac output increase. For blood pressure, it decreased early in gestation due to vasodilatation, but diastolic blood pressure may gradually increase, especially in the last trimester. The heart size increases due to increased volume. Systolic function increases first, but may later decrease, probably in the last trimester. For overall change in coagulation function, in pregnancy, it's became in a status of hypercoagulability. Also, increased uterus would obstruct venous return, causes stasis. So there's further risk in thromboembolism. The metabolic change is also to meet the fetal maternal demand. The glucose homeostasis will change and cholesterol level increases. This physiological change causes pharmacodynamic change during pregnancy. Overall, drug clearance would increase, but the degree of increase varies during different stages of pregnancy because different physiological change. During delivery, a hemodynamic change could be dramatic. There's some maternal factors like uterine contraction and other factors like anesthesia. A cardiac output increase, especially during labor, could be very dramatic. It increases up to 50% during the delivery effort and could be even higher just after partum. The next session will be a quick review for diagnostic tools of these diseases. The first is always a history taking and physical examination. For history taking, watch for possible family history of sudden death. And physical examination should focus on assessment of dyspnea. Watch for signs of heart failure. For further management, blood pressure measure and proteinuria are the most important things. ECG is mostly normal. Some ECG change is usually due to a change in heart position because it enlarges. For patients with known arrhythmia, Holter recording may be considered. Echocardiography, especially transthoracic echo, is the preferred tool to assess cardiac function. Transesophageal echo is indicated in some rare conditions, but is relatively safe during pregnancy. Exercise testing is best done for patients with known diseases to assess pregnancy risks. If this is going to be done during pregnancy, ESC suggests to perform submaximal exercise in asymptomatic patients. W-time stress test should be avoided. Semi-recumbent bike is probably the most comfortable for a pregnant woman. MRI is probably safe, especially after the first trimester, but the long-term effects of gadolinium ion to fetus is unknown, so gadolinium should be avoided. The effect of radiation exposure is affected on two things, the dose of radiation and the gestational age. Generally speaking, if we reduce the dose to less than 50 milligray, it's usually safe. Most current diagnostic tools is below this limit. Even with very limited dose, chest X-ray should be preserved if other tools could not make correct diagnosis. CT is therefore not recommended because a higher radiation dose, with only one exception, if pulmonary embolism is suspected, they should be done. If cardiac catheterization is needed during pregnancy, then we should do every effort to minimize radiation exposure, such as sheathing, radio approach, 3D mapping system. Let's go to a little detail about intervention during pregnancy. For percutaneous therapy, it would be best when the fetus is around after the 4th month in the 2nd trimester. So that will avoid the most vulnerable first trimester and do everything to limit radiation exposure and be strict with the dose of heparin. For cardiac surgery, most currently the maternal mortality is as the same for non-pregnant women, but fetal mortality is still high. We will leave the details of cardiopulmonary bypass to the specialist, but of course we know we should limit the time of bypass. I think this is the last part for the general session. It's about risk scoring. And that is what we discussed in the previous one about pregnancy. So the first thing to consider, that's two key. It's the first is the specific heart disease, and the second is the clinical condition of the patient. And you should be assessed by a multidisciplinary team, especially in the center. WHO risk classification is a very good tool because it integrates all known maternal risk factors, and it categorizes into 4 classes. Class 4, in class 4, pregnancy is contraindicated. And you then may refer to this table to see your patient falls into which category. Okay, we're about halfway through. And the next part is for some specific cardiovascular diseases. We will only summarize 3 diseases, all with possible life-threatening condition. Let's start with cardiomyopathy and heart failure. This is rare, but it could cause very severe complications. We'll focus on peripartum cardiomyopathy. The severity of heart disease predicts more mortality and adverse outcome. So watch out those with poor LV ejection fraction, right ventricular failure, or hypotension. If heart function deteriorates during pregnancy, reassess the safety of pregnancy. The same, it should be assessed with a cardiologist and obstetricians together. Just be careful that the development of heart failure or the deterioration could develop very rapidly. There are some non-predisposing factors for peripartum cardiomyopathy, such as multiparity, smoking, diabetes, eclampsia, and age. It usually happens in the end of pregnancy or following the first months, just following delivery. Of course, echo is the imaging modality for diagnosis. Initially, poor LV function, dilated LV, and RV involvement are very poor prognostic factors. Here is a very important take. For these patients in cardiogenic shock, or they are dependent on inotrope or vasopressors, transfer them early to a facility with mechanical circulatory support team available. For acute management of peripartum cardiomyopathy, consider urgent delivery if the mother is hemodynamically unstable, even under treatment, no matter what gestation age. There should be mechanical circulatory support immediately available. This patient is very sensitive to side effects of beta-adrenergic agonist, so maybe levosimendan would be a preferred choice as inotrope. As for medical therapy of heart failure, if they are still in pregnancy, RAS inhibitor and aldosterone antagonist are contraindicated. For decongestion, loop diuretic and thiazides are safe. The treatment should continue for at least 6 months after recovery of LV function, followed by gradual tapering. I put a question mark on this because I think current consensus suggests to keep heart failure medication, even those with transient factors. I think maybe we could have a discussion about this later. And for this drug, I don't really have any experience. Bromocriptine is a dopaminergic agonist. There are studies showing that with addition of this medication, there is LV recovery improvement and clinical outcome in patients with peripartum cardiomyopathy. Since this patient has a quite high rate of recovery, devices should be considered later. It's usually 6 to 12 months after first presentation. For indication of ICD and CRT, this is the same as for those with reduced ejection fraction. Cardiac transplantation is of course reserved for those with no choice, but patients with pericardium cardiomyopathy have higher rates of graft failure and death after transplantation. And for transplantation recipients, a pregnancy should be avoided for at least 1 year after transplantation. If urgent delivery is needed, it's better in a control setting with a cesarean section or under spinal anesthesia. If the patient is relatively stable, then vaginal delivery is preferred with either spinal or epidural anesthesia. For breastfeeding, in severe cases, this is disencouraged. So the key point in management of acute heart failure during pregnancy is rapid interdisciplinary workup with multiple specialists, but a very quick assessment. It should be done in only a few minutes. For cardiologists, the first is to confirm diagnosis. It may not be easy because some physiological change during pregnancy, the symptoms just the same as heart failure. If you confirm the diagnosis, the second is to assess if there is shock, assess vital signs and target organ perfusion. If the patient is in shock, manage acute condition first, assess if urgent delivery is needed, and the rest is as for management of acute heart failure and cardiogenic shock. If the patient is stable, then the medication choice depends on the status of pregnancy. In those still pregnancy, avoid RAS inhibitor and MRA. This is a recommendation table for your review later. We'll now go to the second disease, coronary artery disease. We'll focus on acute event. ACS is not quite common during pregnancy, but coronary artery disease accounts for a part of maternal death during pregnancy. Pregnancy does increase the risk of ACS, especially in those with older age. For patients with non-coronary artery disease, pregnancy is okay for those without residual ischemia and clinical sign of LV dysfunction. ACS during pregnancy usually happen in the last trimester and postpartum. And the cause of these ACS is usually non-atherosclerotic. It's different from traditional coronary artery disease. The most common etiology is spontaneous coronary artery dissection. The diagnosis is all the same, with symptom, ECG change, and the change of cardiac biomarker. But timely diagnosis is often difficult because the presentation is not easy to differentiate. There are some traditional risk factors like CAD risk factors, but there are some other factors during pregnancy, such as eclampsia, transfusion, substance use, and hemorrhage. Again, this should be managed by a multidisciplinary team, and invasive strategy is indicated if the patient is in deterioration, and revascularization should be performed by the most experienced operators. For intervention during ACS, primary PCI is indicated for STEMI. Thrombolytic therapy is only reserved for those without access to PCI. For non-ST elevation ACS, invasive approach is considered for those with high risk. You may consider a conservative management in those with stable conditions. For choice of dual antiplatelets, the safest choice is the old combination, aspirin and clopidogrel. After an acute event, this guideline recommends about a 12-month delay before next pregnancy. And of course, this should be individualized. There's no high-quality data. There's a quick recommendation for this part. We go to the final part for valvular heart disease. In this section, there's two subsections. One is for mitral stenosis, and the next is mechanical prosthesis. For patients with mild mitral stenosis, it's generally fine. And those with severe diseases, poor symptoms, higher PA pressure, risk of pregnancy thus increases. The complication rate differs in country, and it's higher in lower or middle income countries. And offspring risk could be quite high. If the patient has symptoms, use diuretic and beta blocker. Also, restriction of activity also helps. Anticoagulation is indicated for those with atrial fibrillation, airway thrombus, or prior embolism. For some conditions with high risk of thromboembolism, such as spontaneous echo contrast in LA, anticoagulation should also be considered. Patients with significant mitral stenosis, that's a more severe disease status, pregnancy is contraindicated. They should be advised against pregnancy. If they still desire pregnancy after counseling, intervention should be done before pregnancy. If intervention is indicated during pregnancy, that's usually when patient still unstable under medical treatment. The choice is percutaneous mitral commissurotomy. Open heart surgery is safe for life-threatening condition because very high fetal risk. The frequency of follow-up is determined depending on hemodynamic tolerance. And the delivery mode is based on disease status. For those with more severe disease, control setting with cesarean section is preferred. And it usually needs close monitoring even after days after delivery. This is a quick review for this part. Now we come to the very last part. It's for the mechanical prosthetic. For patients with mechanical valves, pregnancy is with a very, very high complication. This is because of anticoagulation. One side is the risk of bleeding, and the other side is risk of thrombosis. For the choice of anticoagulant, vitamin K antagonist is the safest regimen to prevent valve thrombosis, but low molecular weight heparin has a lower fetal risk. So we should discuss with patients before pregnancy about anticoagulant regimen, and it usually needs very frequent monitor, at least every 2 weeks. The choice of anticoagulant is partly depend on the dose. If the patient is on a smaller dose, that is less than 50 milligrams of warfarin, then in the first trimester, since the drug dose is lower, vitamin K antagonist is still preferred. Of course, you can choose low molecular weight heparin or heparin. And in the second and third trimester, because there's fetal risk in this duration, so warfarin is the preferred choice. And before delivery, the preferred choice is heparin. For those with higher dose of anticoagulants, that is more than 50 milligrams of warfarin, in the first trimester, to reduce fetal risk, heparin is preferred than warfarin. In the second trimester, you may continue warfarin. Before delivery, of course, again, heparin. While you have any suspicion of valve thrombosis, you need to perform an immediate transthoracic echocardiography. And we know if we want to have a better visualization of mechanical valve, you usually need a transesophageal echocardiography. And if this diagnosis is confirmed, valve thrombosis, we have to optimize anticoagulation. Surgery is reserved for those with medical failure. And fibrinolysis is for only very small group of patients. If one is that if they cannot have surgery, and the other is in right-sided prosthetic valve, this may be considered a therapy of choice. But personally, I already have no experience of this. This is a recommendation table. So this is the end of this part. And we'll have a quick take-home message. During pregnancy, there is some normal physiological change, but this change will make diagnosis of cardiovascular disease very careful, very difficult. And evaluation and management should concern mother and fetus. For management of the specific diseases, because this is not really not common in everyday practice, so I suggest we refer to the most recent guidance for the help of specific management. And overall, this should be evaluated by a multidisciplinary team. And remember to transfer early if you think this patient needs to be cared in a special center. This is a quick review, and I'm looking forward to discussion.
Right. Thank you, Dr. Lin, for the wonderful talk. Actually, this is actually the first time we've discussed cardio-obstetric in our series. We missed it the first series because of time limitations, so it's quite refreshing to have such a topic discussed. I'm waiting for some Q&As to pop in, but while we're waiting, does the panel or the floor have any questions? Dr. Leong, Dr. Wei-Ting, Dr.
Or
Rina.
maybe we could discuss if you would start medication for heart failure in a case with a peripartum cardiomyopathy, if she does recover fully.
Yeah, no, so that's the big question mark. Actually, I've got my 2 cents about the situation. I'm quite fixed as well, but I want to hear what other people think. So, Dr. Wei-Ting, what do you think? Patient, peripartum cardiomyopathy, on all GDMTs or guideline-directed medical therapy, and so happens to have full recovery. And the definition of full recovery is the one that's with a big question mark. What do you think?
Okay, good. So actually, just have several patients who has experience with peripartum cardiomyopathy. I think the most important thing is about what's the previous history, before pregnancy. So because some is kind of fully recovered, supposedly they don't have specific cardiovascular disease, and this is just because of hormone or like overload burden to induce the myocardial dysfunction. But the other possibility is they also already have pre-existing cardiovascular dysfunctions, and this kind of pregnancy-induced overload just exacerbate and make the symptoms happen. So my previous case, as one is has fully recovered, but we still give the heart failure medications, the 4 pillars. And I think if we evaluate the myocardial functions after deliver and everything is going well, and I will try to just taper the medicines, but at least I will still keep one like beta blockers to see if it still can have some like benefit to the heart. But till now, actually, no, we just want to follow guideline, but we don't have much evidence about that. So currently, I still keep one medicines, and I still keep look and to see if we need to, we get the chance to take off all the medicines. Yeah, but the other patient actually, I think it's very possible she hasn't been diagnosed with heart failure before pregnancy. So after the delivery and still try the different kind of medicines, but those medicines traditionally it will work for the heart failure, but doesn't work for her. So currently she's on the list for myocardial heart transplantation. So I think sometimes it's very difficult, to evaluate, what kind of strategies is suitable for one. Maybe we don't have one for all, but need to evaluate individually. This is my experience. Just want to experience from the other chair.
I think this is a very it's a data-free space at this point in time anyways. And I think you're absolutely right. We don't know what the patient actually has, and there has been papers where when they've done genetic testing on those deemed to have peripartum cardiomyopathy, they found a significant number of patients who actually have genes that are linked to dilated cardiomyopathy to begin with. So, are we actually missing them? They've been very silent or subclinical throughout, and then pregnancy was just the trigger that was needed to push them into dilated cardiomyopathy. Dr. Leong, well, what's your take? And you're an MRI expert as well. I just want to find out from you, what would you say is full recovery, or what parameters do you use in your clinical practice to tell you that, okay, this patient may be actually have fully recovered?
So the problem with our practice with patients with peripartum cardiomyopathy is that we do not have the pre-existing pre-cardiomyopathy ejection fraction. So I don't know what's the baseline that they should
Sure.
recover to. So we will take an arbitrary about 50 to 60% as the cutoff. If the ejection fraction improves up to 50, 60% and remains so for the next 1 year, then, because of the cost of the GDMT medicine, we would perhaps wean down this medicine and keep them on one medicine and keep a close eye on them. I would say that, we don't have proof to say that, it's advisable to wean off medication, but because of the economic reasons now, I would say. This is our
And
practice. Yeah.
right. And do you, I don't know, in your practice, do you use MRI to sort of guide to say whether, okay, this patient actually doesn't have any more gadolinium enhancement after 3 months, after 6 months, something like that. Therefore, you're a bit more confident that, maybe the LV has recovered, or do you not use that?
Unfortunately, sometimes we don't get any late enhancement in patients with peripartum
True.
cardiomyopathy. Yeah, we have no clue at all. We just had a heart function which is depressed, and then with no late enhancement. In this case, late enhancement isn't really helpful. So we just go by clinical, go by the symptoms, go by the ejection fraction, and from there we just wean off the medication accordingly. But luckily, most of these patients improve over time.
Yep, true. And Dr. Rina, what's your take on this?
Yeah, I think it's a great issue about the fully recovered ejection fraction. I usually do strain for my patient because sometimes the ejection fraction show is already normal, but if we do the strain, there is still subclinical LV dysfunction. So usually before I try to taper the medication, I have to make sure that the GLS is also comes to normal level too.
Yep.
And then maybe usually I maintain the drugs until usually either ACE or beta blocker. I keep it until maybe a year, and then I make sure again that the strain is good, and maybe we can try to stop one of the medication, and then let's see about it after that, and then try to stop another one, and then see about it after that. So I usually use strain to make sure that it is fully recovered.
I think that's a wonderful point. I use and abuse strain a lot as well. But I think the data isn't that strong yet for strain, especially in peripartum cardiomyopathy and looking at recovery. But we know what is strain, we know what the value is. And yes, instead of doing an MRI, which can be a bit challenging cost-wise, pragmatism-wise, strain seems to be something that is a bit more accessible, I guess, for most people. So yeah, I do also use strain to add an additional parameter on top of everything else, clinical and non-clinical. Do you have any other questions from the floor? Yeah, we do have some questions. So first question from an anonymous attendee. Dr. Jia-Ling, do you want to type the answer, or do you want to answer live?
I think I could have a word for this. In the guideline, there's no specific cut-off value for the start threshold of medication. I think generally the principle of heart failure applies. So I think I would start medication in those with reduced ejection fraction,
Yeah.
maybe at 40%. And it
Yeah.
does states the principle of medication. For beta blocker, it's just the same. Start slow and go slow.
Yeah. And I think since we're on that topic about starting medication, I think one of the things that you showed alongside, the 4 pillars that we normally use is also bromocriptine, which is a very European-pushed sort of treatment option for peripartum cardiomyopathy. Of course, we've only got an hour and a half for this particular episode, but I like to bring people to, I like to bring people's attention to the consensus paper from ESC that talks about the BORD scheme, BOIRD, which talks a bit more about bromocriptine and how you dose it as well. Right? So just for people's information, I guess. The next question, if the EF improve and normalizes for peripartum cardiomyopathy, I'm guessing, current GDMT support of continuing treatment is left with SGLT2 inhibitor. Not too sure, but do you want to try and answer, Dr. Jia-Ling?
I'm not really sure because most trials exclude these pregnant women, so we don't really have much data about this.
Yeah, so I think for now, SGLT2 in pregnancy still remains, a big no-no because we don't have the data per se. So I think that's quite straightforward, really. Any other questions from the floor? that you'd like to ask? Well, Dr. Wei-Ting, yeah, go ahead.
Yeah, may I have some feedback? Actually, I think the ejection maybe not a very nice parameters to evaluate the myocardial function. I prefer strength. Actually, because sometimes that's in pregnancy, the patient will like in the hyperdynamic status. So sometimes the blood pressure, the tachycardia, and all these will contribute to the overestimated ejection fraction. So we evaluate maybe like a 60%, but actually myocardial function is not as good as what we see. So I think the other evaluation like a MRI or like a strength will be more helpful. And the other about the medicines, actually, if it's still in pregnancy, a lot of medicines is contradicted. So I would prefer, sometimes like beta blocker like Candate. These kind of drugs can be used in patient who has like a pregnancy-induced hypertension. So, but the other drugs kind of lack of evidence. So I think the other point is have a very nice, talk with the obstetric, just the doctors to see, when is the proper time for deliver. Yeah, so like for the babies, like before, we can have the just an age, like more than like a 27 week. I think it would be okay for this baby to be survived. And but if we can keep it longer, often it's better. But sometimes it will be kind of threatened to the mother. So it's very difficult and need like SD and shared decision makings about that. This is my opinion. Thank you.
Excellent point. There's another question that I wanted to ask really, and it's about the CT scan. So I think in Dr. Lin's presentation, she mentioned that a CT scan in pregnancy, really the strongest indication is for a CTPA for pulmonary embolism, acute pulmonary embolism at least. But what is your take on using MSCT, CT coronaries in the setting where you suspect there is coronary artery disease or an acute coronary syndrome per se? Have you ever had experience per se? Do you know what the guidelines say about using CT scans for coronary assessment during pregnancy?
In this guideline, coronary CT is not mentioned. I
Right.
think it's because of there's both radiation exposure and contrast exposure.
Yeah.
So no recommendation from this guideline.
Yeah. And, again, open to the floor. Anyone has had experience using CT scan as a surrogate or a substitute for, invasive coronary angiography in your patients you suspect of coronary disease? Dr. Leong?
I feel that, in order to do a radioactive investigation, the indication has to be quite clear.
Yeah.
For example, you have a suspect to have a pulmonary embolism, it's emergency, then the risk doesn't outweigh the benefit, the benefit outweighs the risk, then it's worthwhile going for the procedure. For example, the patient has a chest pain and then the cardiac enzymes is raised, rather than fiddling with the CT, and if CT is positive and then you have to go for angiogram, I think it's better to go straight for the angiogram. It confers a slightly high radiation rate, but then it gets the work done, gets the disease treated. I would go straight for the desired treatment per se, rather than going for a few testings.
True. So, Alara, I guess that's a concept, isn't it? As low radiation and try to get to answer your question as much as possible.
Yes, that's right.
Yeah. Okay. Any other questions on the floor?
I think we have a question from the floor, from the audience.
Yep. So, any studies on echocardiography changes on preeclampsia patients? Most patients with cardiac issues would have risk factors for preeclampsia, agree, and clinical presentation is almost the same and would be blurred or would be a bit vague. So, open the floor to Dr. Lin.
I don't really have answer for this, but I think for eclampsia and preeclampsia, meaning with spike with hypertension, and possibly some might be also change from strain, I suspect, but other parts probably not much.
Yeah. I think you can think of it as a reverse, really. There are some guidelines or some papers or review papers telling people about the common changes you see on echocardiogram as the pregnancy proceeds. So, anything that's beyond that would be reasonably abnormal and you want to investigate if the signs and symptoms fit. So you do have some expected changes on echocardiogram during pregnancy, throughout the pregnancy as the weeks go by. And anything that's beyond that or diverges from that, something to probably investigate if, again, the clinical context is important. And the next question is, CTA for patients less than 40-year-old is contraindicated. Good point. Yes. Haha. Excellent point. The other thing that I really want to mention, and I think it was highlighted very clearly from Dr. Lin, is when you talk about mitral stenosis, it is mild mitral stenosis and everything else, which is very important. We no longer talk about mild, moderate, severe, because even moderate mitral stenosis can be very significant. And we've had patients where moderate MS, not pregnant, absolutely asymptomatic, and then they get pregnant and all sorts of symptoms suddenly appear. And then we're scratching our head, okay, is this something that we need to intervene? Is the pregnancy going to be okay? In your practice, Dr. Lin, Dr. Leong, Dr. Rina, Dr. Wei-Ting, how do you assess this kind of patients where symptoms manifest only with the pregnancy and the patient is sort of having a moderate valve lesion based on echo parameters? Maybe start with Dr. Leong.
I would say that most of my patients with mitral stenosis, during pregnancy, they are fairly asymptomatic. They usually go into acute pulmonary edema after delivery, when the fluid suddenly, gush back to the mother.
Right.
So during pregnancy, they are fairly asymptomatic. And then the decision is, if the patient's asymptomatic, but the gradient is high, when would you want to intervene? I think this is a very critical question. So there's no perfect question over here.
Yeah.
So it boils down to your MDT discussion and what suits your center best. So if you feel that you can deal with the acute pulmonary edema better post-delivery, then you go ahead and weather the storm. Some people would be more adventurous and they will do the PTMC intrapartum.
Yeah.
But whenever I see a patient with mitral stenosis, the first thing I do is to check the heart rate, to make sure that I bring down the heart rate as low as possible, as low as tolerable. And in doing so, I also monitor the fetal growth to see whether the beta blocker actually affects the fetal growth. As long as heart rate is okay, I'll notice usually that the gradient across the mitral valve will reduce. Then the estimated mitral valve area will be higher. If it's still less than 1 cm square, I would have an MDT, and in our center we tend to have a lower threshold for PTMC if the patient is suitable.
Right. Great. And Dr. Rina? Oh, sorry, Dr. Lin. Yeah, go ahead.
Yeah, Dr. just mentioned a very important part. Those with severe disease but asymptomatic. In this guideline, the committee does suggest to consider intervention in those with severe disease, although asymptomatic. And severe disease mentions that is mitral area less than 1 centimeter square.
Great. Dr. Rina, what's your take on this?
Yeah, I think for mitral stenosis is quite challenging because clinical presentation at sometimes it's not quite perpendicular with the severity of the mitral stenosis. Sometimes the mitral stenosis is considered moderate, but the symptoms seems quite severe. But sometimes it's already below 1.0 centimeter, but the patient seems okay. So we usually, if the patient is asymptomatic, I agree with Dr. Leong, we try to reduce the heart rate and close monitoring of the patient. But if the patient is asymptomatic, we usually do PTMC during pregnancy, usually I know the guidelines say it's supposed to be done in 2nd trimester, but we usually do it in the 3rd trimester to make sure the baby is quite all right if there is something happen during the PTMC. So and if the patient is asymptomatic during pregnancy and we can lower the heart rate by using beta blocker, I think just make sure the delivery process is smooth. Hopefully the patient can goes fine after the delivery, and then we can deal everything after the baby's born.
Great. I think the last question Dr. Lin has answered, and I think it'll probably be yes, you should intervene, as you've mentioned, severe MS before pregnancy. So that's quite good. Okay, so actually we've run we're now headed to 7:30, so I do have to close the session. I'd like to thank all the chairs, Dr. Wei-Ting, Dr. Leong, for helping chair this particular episode. It's been a wonderful episode. I'd like to thank the speakers, Dr. Rina, Dr. Lin, for again presenting wonderful summaries of very big guidelines, and we weren't sure whether we could actually make it to 7:30 today, but we did. So bravo and kudos. I'd like to thank all the audience as well for participating. Very good questions on the floor. A lot to think about. A lot of gaps in the data, clearly, as we've highlighted, but very relevant questions. Just to remind everyone, the 22nd of January 2025 will be our next episode, and we'll be talking about coronary artery disease, both acute coronary artery disease and also chronic coronary syndrome. So please tune in and please sign up for our webinar. And with that, I'd like to end the session today. Thank you everyone again, and have a pleasant night ahead. Thank you, guys.
Thank you, everyone.
Thanks,
Bye.
thanks, thanks.